May, may I welcome everyone who has joined us today. I've seen that our case presenters already logged in, and I'm hoping also others will be joining us very soon. So we are looking forward for another great session even today. Last session, we were looking at a very critical topic, which was on anorexia and cachexia. So today we will be looking at another symptom, which is xerostomia. So we'll be looking at that one, but maybe to bring back on what happened in our last session, we looked at cachexia and anorexia, which are some of the common symptoms in palliative care. And we said that one of the things we need to do is to understand that refractory cachexia is not reversible. And whenever you are planning to reverse any symptom, it is very important that we consider the ethical part of whatever we are doing and put the patient as the center of our interventions. So we mentioned that it's not ethical and legal for us as clinicians to continue with interventions, whether pharmacological and non-pharmacological, knowing very well that it's not going to help the patient, because then the person who end up paying the price, it's the patient and the caregiver. We also mentioned that around cachexia and anorexia, there are the cultural aspect of it, especially when it comes to us in Eswatini or Africa, that we believe that for a patient to live long, he or she needs to be fed until the end. We think that sometimes feeding our patient who's cachectic, they will gain weight and come back to life. Yet, once they've developed a cachexia, you find that feeding them will not help, because it will only give the patient developed the fat mass, not the muscle mass which we are looking for. And that normally is lost during cachexia. So we also hinted on the issue of artificial nutrition and hydration, that sometimes artificial feeding is good to a certain extent, but most of the time in patients with cachexia, it is not beneficial. Sometimes you will think if we can feed our patients artificially, they will gain mass, or if we can artificially hydrate them, they will gain mass, only to find that normally it doesn't bounce back or help them. So then that means that whenever we are planning to intervene in such a situation, it's very important to consider such issues very important, and weigh between the benefits and the harm that we are going to cause on the patient, and then able to educate our patients and counseling our patients on the prevailing symptoms also helps them be able to cope with that distressing symptoms and be in a position to attain that quality of life. So that was very important. So the conclusion is always when you're managing such a symptom, cachexia and anorexia, involve the patient and the family. So you move together in the management. So that's what we were looking around. And then we also had a case from Lubombo, almost of the same case. So we shared about it. So today, we are moving a little bit better to another baby, which sometimes results to anorexia and cachexia. One of the symptoms we've also treated is constipation. So we are looking at this most common symptoms. So today we'll be focusing on xerostomia, and especially under the main topic, mouth care. So then after this presentation, we will have a presentation from RFM Hospital. So they will be sharing with us their case for today. So we are looking forward for a great session with today. May I try to exit the screen? Yeah. So I hope you can all see my screen. So I hope you can all see my screen. You can type yes, or you can unmute and tell me yes. If you can see it, I can appreciate that.
My side, I can see it well.
Thank you, Joshua. I hope you are doing well, my friend.
I'm doing well. Thank you so much.
Thank you so much, colleague. So today we'll be looking at mouth care and xerostomia, especially the symptom we'll look at on the aspect towards people with life-limiting conditions. Remember, in palliative care is for people with life-threatening and life-limiting conditions. So whenever we are discussing issues here, the principles that we are using here are for people with life-limiting illnesses, or we call them serious illnesses, of which most of them you find that even a recovery is not possible. Sometimes we can anticipate that the trajectory will go down, and then you can expect that person to die at some point, not now or due to the condition, or sometimes we expect that our patient will recover and be okay. So we're going to look at what is the xerostomia, we're going to look at what causes it, and then sometimes we'll look around on the assessment that we can do, and then the management that we have. And today I would request that we all share. I hope we have seen this symptom at some point. So that's looking at mouth care. This is one of the very critical organ or area in palliative care for patients who are transiting even towards end of life. So it's very important, even for anyone diagnosed with cancer, organ failures. You know, when you are diagnosed with life-limiting areas, the mouth becomes the very important organ, because one of the principles of pain management or medication administration in palliative care is PO. So we give it by the mouth. So this is the first area that we need to be very critical of and take care of it always as possible. The mouth, we know, is for eating and drinking, which is one of the things we expect our patients to do. You know, when we are saying drink 2 liters or 3 liters a day, it's where they taste and communicate, you know. So they communicate with us, they use their mouth. You know, when your mouth is smelling bad and you can tell that, you know, you have maybe oral case, I'll make that one example, or you have a very bad mouth. So you end up not communicating and your self-esteem goes down. That when then anxiety, depression, all those psychosocial issues, cultural issues, they kick in and the patient might not cope very well. So it's for breathing and defense. You know, we know there's mucin in the mouth, which is for bacterial defense. So this is the very important organ even in palliative care. So we use it for medication administration. I've mentioned that one. So another thing that why we need to provide mouth care is that problems in terminal illnesses really impact the quality of life. And most of the issues that will come through the mouth. So we need to, mouth care problems will result to a severe impact in the quality of life. So you'll find your patient deteriorating very fast only to find that your patient has a problem with the mouth. Currently, we have a patient who has developed a serious problem here. He has been on NG tube, so the caregivers couldn't provide good mouth care. So then there were challenges. And then even mild discomfort impairs speaking. So when the patient has a discomfort in the mouth, you will find that they are unable to communicate. Yet in palliative care one, we have to communicate goals of care with them. We have to know what they want. So we have advanced care directives. We have consistent communication, which is the strong pillar in palliative care. So we need them to talk. So even a small discomfort in the mouth will lead to eating problems, and then which will lead to what? Aggravating the nutritional problem, which will be anorexia and cachexia. So when there's a problem with the mouth, then if you remember, one of the causes, the reversible one, is when patients have mucositis. So this is one of the problems. So if the mouth is challenged, is a problem. So part of the researches I've seen through is that 90% of palliative care patients experience dry mouth or xerostomia to varying degrees. Some 50% in frail patients, especially the patients who have cachexia, you see, those ones who have lost more bone mass, who are very frail. You'll find that 50% of those patients, they will experience dry mouth. And then 80% of patients who are at end of life. So that's why you are saying hospice, and then 100% who are HIV positive. Those ones, they always experience that. So dry mouth is there. So we need them to look around it because sometimes we ignore it. Okay. So then looking what in general I can say xerostomia is. So I said that it's the reduction in the production of saliva in the terminal stages of the disease. You know, when they're approaching the end. So one of the things you'll see, they'll see that they experience more of the xerostomia, and as I've mentioned, 90% of those patients. So as they are approaching the end, so when you have your patient who is deteriorating with the palliative care phases from stable to unstable, deteriorating to terminal. Once they approach deteriorating to terminal, one of the things you will see, they will consistently have xerostomia. And that's one of the issues that will show this thing, you need to manage it as possible as you can. And then persistent dry mouth is associated with discomfort, burning, scaled sensation, and loss, altered taste and appreciation. Okay? There's difficulty with chewing, swallowing, or speaking. Sometimes the saliva function that we need to understand is that saliva comprises the mucin and fluid, which is 0 to 1.5 liters daily. So there's a lot of fluids there in the mouth to keep us the environment moist and lubricated, to protect the teeth and the mouth and gums, and to maintain oral health. So you need to have this enough saliva. That's why we have to control between the drowsiness and then also mouth dry mouth, because then when they have more saliva, then it's a problem, and when they have no saliva, then it's another problem. So we need to balance between those two. So sometimes there's a protection there and the pH management, so the teeth could be contained with the calcium in them. And then when we say then there's xerostomia, you will find that it comprises of appetite and nutrition problems. It comes with self-esteem, you know, when you can, have you been dehydrated, you know, you can't even speak when your mouth is dry. So that's what the patient goes through. And then also what happens then when they have this dry mouth, it predisposes them to infection and dental complications. You know, when they are approaching the end, these patients during the transition, normally you find that they keep on opening their mouth. They can't close their mouth, so it's like they are breathing with the nose and the mouth most of the time. So then the mouth quickly becomes dry. So yeah, that's one of the things we normally see. And then once that happens, they will end up having infections. Sometimes they get infections because of flies, because they can't even beat away flies. So they go through those situations. So we need to support them and take care of them. So the reason then we are looking at this topic is that patients and clinicians, as clinicians, will frequently disregard the symptoms of dry mouth as not serious enough to mention or deal with. Okay. We feel like, not dry mouth, there's no problem that much. Yet it's very serious, and we need to deal with it because it comes with a lot of psychological and spiritual and physiological effects on the patient. So that's why today we are looking at this xerostomia. Okay. So then what are the causes of xerostomia, especially in life-limiting illnesses? Okay. So the first thing that it appears in three categories. There's one, reduction in saliva, then buccal erosion, and then the local systemic dehydration. So these are the three categories that these causes come through. So when we talk of reduced salivary secretion, normally it's caused by medication. Okay, if your patient is taking anticholinergics, your patient is on opioids, a patient is taking diuretics, a patient is taking alcohol containing mouthwash, one of the things that your patient might experience is that he will experience dry mouth. Then infections, sometimes there's tumor-induced salivary glands destruction, especially when your patient will find that they have mouth cancers. So then they are prone to dry mouth. And then another issue is treatment, chemotherapy, and radiation. There's what we call radiation-induced xerostomia. So once your patient is undergoing radiation or chemo, then they experienced xerostomia. So if you look at these causes on the reduced salivary secretion that deals with the gland, you can tell that one of the drugs that we are using most of the time, which is one of the one that drugs in palliative care, which is opioids. These drugs, they have a lot of side effects. So one of the things that screen your patients now and then if you know they are taking opioids, because that's one of the issues they will be going through. Let alone then if my patient now is a tumor that will be dealing with this gland, let alone if then my patient is on chemo and is an opioid. So the risk of developing xerostomia is high. And remember, once it develops xerostomia, my patient could be pushed to anorexia and cachexia and then mortality. Another one is the buccal erosion. Sometimes also when the buccal is eroded, is due to also chemo. You see, these drugs we are saying we are trying to help the patient, but they have a lot of problems that usually comes with them. So we need to assess and manage the symptoms and allay anxieties where possible. Sometimes common immune-related conditions like this one, diabetes mellitus, Xerostomia, Alzheimer's diseases, HIV, and etc. So when it comes with immune compromise, so also it happens with them. So then when we talk of local system dehydration, we look at a spectrum of conditions here. Sometimes when my patient he has debility, which might be anorexia, cachexia, and my patient is vomiting, they might end up having xerostomia. If my patient is suffering from diarrhea or a fever, currently in our home-based unit, we are receiving more clients who are requiring, who are dependent on O2. Post-COVID effects, some have lung cancer and etc. So we are receiving such clients and we are seeing them coming into palliative care and they are consistently on O2. So then, that's why it's very important for us whenever we are visiting at home to check the O2 flow and to see if they've plugged the humidifier very well and if the air is passing through the fluid or the water or the normal saline, because that one also can lead to xerostomia, and then it may complicate the situation. Sometimes if they are mouth breathing, I mentioned that some of the clients, we see them in home base. I don't know, for those who are admitting, maybe they do during their rounds, that when they are approaching the end, in their last few months or days or weeks, you will find that they are using their mouth to breathe. And then in that way, you will discover that then they completely have xerostomia and then they will have problems. And then I will not mention the polyuria because antidiuretics and stuff. So dry mouth sensations are worse at night. So then your patient will say to you, I don't sleep at night, okay? Once my patient say I have insomnia, I can't sleep at night because I feel like my mouth is hard, like the larynx, they become hard because the xerostomia is kicked in, so the patient cannot sleep. because it becomes very worse at night. So these are some of the causes. What I will need to emphasize here, let's not wait for the patient to have the problem, but let's do assessment. In short, we are saying let's be proactive, not to be reactive, but let's be proactive to this patient, because now we know that these patients are prone to it. So let's do some mouth examination, asking the patients, okay? So then it leads us to assessment then. Now that we know this could be the causes, and now we see many of the drugs we are giving our patients that could lead to xerostomia. And then let's look at the assessment. In the assessment, you ask the patient, so how frequently do they experience dry mouth? It's very nice when you have the background data on before anything happens, then you need to know, so the patient can tell you any changes he has seen, even the patient experience, how is the dryness affecting him, also the history of tobacco use, because if they are taking tobacco and they have these conditions, you know, except that it affects pain management, may lead to opioid use disorders. Another issue is that it leads to xerostomia. Another thing is that in the current situation we have in our country, that sometimes the drugs are not available for the clients, so they end up have to use OTs. So if they are going to use OTCs, medications, then you need to find out what medication they are buying. What my experience with this patient is that you request them to buy once, especially the medication that can be accessed over the counter. You request them to buy once. They never stop buying. They keep on buying. If I will come with Scopex, maybe to reverse saliva withdrawing, and then I prescribe the Scopex to that patient, and then it works for the patient. Then the relatives will never understand that I prescribe it for that only. If then I have never communicated very well, they will keep on buying it, and then it will push them to xerostomia. And then what we also recommend is that we do oral examination, we do the intraoral examination and the extraoral. When we're looking at the intraoral, we look at the characteristics of the mucosal membrane, the buccal areas. You look for the presence of dryness and fissures in the tongue. When you see big cracks in the tongue, that one tells you that there's a big problem here. Sometimes once they have xerostomia, it will be accompanied sometimes with the candidiasis. So you look very well closer, sometimes with gingivitis. So you look very close at what is happening in the mouth. And then also you look for extraoral, then we talk of the lips. We talk of it, how the lips are they angular, is there any angular cheilitis? You know, when you find those things, that may be an indication that xerostomia is kicked in. So you do the examination. So now and then just look at your patients, even when they're coming for refill in our facilities, or they've been admitted, or they are our OPD patients. When we are talking with them, look at their mouth. Sometimes request them to open their mouth so you can see what is inside there. So there are certain diagnostic that are there that we can use. So the first one that we can use there are two standard bedside tests for xerostomia that we can use. So there are two. The first one is the crack biscuit test. You know, you just give them the biscuit. You know, crackers they cannot be swallowed easily if there are no saliva in the mouth. So if there's no saliva, the patient will have difficulty in swallowing that biscuit. You will see that the patient will just put it in the mouth and quickly will request it for water. And then that tells you that my patient is experiencing some sort of xerostomia. And then another one that we can, these ones we don't need to have money if they have them. But then if I cannot have the cracker biscuits, then I go for the tongue plate. You know, the ones that we use for examination, the tongue depressors that we have in the facilities. Yeah, you get those ones, and then you inspect the mouth. So what will happen is, if you take the tongue plate, you place it on the tongue. If the patient has sticky saliva, then the tongue plate would stick, will not just flow easily. It will stick in the tongue, and then the patient will have xerostomia. So you can use these two to tell if your patient has xerostomia. So another one that maybe we can use the salometric measurement of saliva. So whereby you measure the amount of saliva collected by spitting on a certain container and then swabbing with a cotton tip applicator or salivating into a test container at a set time. Then you will see if my patient then has burdensome. It will be unnecessary for you to do this, or it becomes very hard for them to do it. Don't do this alternative test. The best one are the two, the cracker and the tongue blades. They are the easiest way to test. If even yourself you are not sure, you can test and see how the tongue blade will move or the biscuit. If you can't swallow that biscuit, you are in trouble. You need more fluid. Okay, but then the one for spitting, you know, find that some patient, they can't do that. Okay, so then when you go for management of these symptoms, these are the steps we can follow. The first thing when you find xerostomia, if you remember when we started this module, we started with the principles of symptom management. So one of the things that after the patient has presented this symptom, I need to find the root cause of the problem, because dealing with the problem, not the roots, I will end up not be effective in my management and end up harming the patient other than helping the patient. So it's very important to find the cause of the problem. So then once we have found the problem, then treat the underlying infection if there are infections. Find maybe there is candida, then you treat the candida behind. And then what you are going to do once you have done any treatment or intervention, then the principle is you review every intervention or treatment prescribed has a review date. There is no IRI in any management in palliative care. So then you review and alter current medication as appropriate. So then if you find your patient that is taking certain medications that are predisposing the patient to that xerostomia, you review that medication and then you measure the effect of that treatment, how much effect is it causing, and then you alter the medication around and see where appropriate. And then another thing you can do stimulate salivary flow. Salivary stimulus can occur with both non-pharmacological and pharmacological interventions. I will share it very soon. So you stimulate salivary production. So for the patient, or replace lost secretions with saliva, or protected teeth, continue with mouth care, or using fluoride rinsings. So you protect the teeth because they are very important to be there. And then you can rehydrate the patient or encourage intake of plenty of fluids. We know that one. If my patient is dehydrated, once they have xerostomia, I will encourage fluid intake. Okay. Remember, when we are talking of fluid intake, it must be based on the patient needs and looking at the goals of care. Because if I'm at my last minute of death and I'm experiencing xerostomia, there you come with your prescription of 2 liters. You know, it's not a good intervention. Maybe getting those ice cubes or getting that Vaseline, you know, those small sips will help, other than giving me 2 liters a day. So another thing we need to also do is to modify diet. Avoid mouth pain from acids and hard foods. Okay, some of the patients, they have this pain in the mouth, and then we need to avoid that and modify the diet so it fits the patient needs. So these are the things we can follow, but then maybe let me just share the non-pharmacological and pharmacological things. I think we can have many. I've just listed a few here that we can have there. So one of the things, the number one, non-pharmacological means, you remember that in palliative care, non-pharmacological means and pharmacological, they may have the same effect. So even in xerostomia, we cannot outweigh the non-pharmacological and the pharmacology only. Both they can work. Even the non-pharmacology can do the work without the pharmacological part of it. So one of those things that we need to do that doesn't need a lot of money from us is to ensure good oral and dental hygiene. Encourage the caregivers to provide good oral and dental hygiene. Keep the mouth clean as possible they can. And then we also have the saliva substitution or stimulation. Okay, so you can do, to stimulate the salivary production, you can give frequent sips of cool water, sugar-free liquids. Okay, oral water sprays, wet sponge sticks of patients is weak. So we use oral sprays. But then we need to know that sometimes the wet sponge might not work very well for us. So sometimes some sprays will work well for the patient. Sometimes we encourage them to get mint ice cubes or ice chips or frozen lemon or pineapple juice, vitamin C tabs or sour sweets. Okay, we encourage them. Now you know, if you can take a sour sweet right now, put it in your mouth, you'll be producing a lot of saliva. So we encourage them to do that, or else they get those, or we get them chewing sugar-free gum, get them that gum so they will chew, by the chewing stimulation, and then the body says, it tells the body to release more because the gland will be stimulated to lubricate that chew gum, yet Okay, another thing that we need to do is lip care. So take care of the lips, cleaning, moisturizing. Sometimes we can use liquid paraffin jelly or Vaseline. That's enough. Brushing it. At some point in life, we need to even encourage the patient that, sometimes when your patient is no longer eating, end of life, no longer eating, now eating from the other world she or he is going to, we just encourage the family members to provide lip care. Simple. Just brush the mouth and put Vaseline. If the patient likes lip gloss, whatever, what do you call these makeup things? Make up the lips to look very nice, And then pharmacological, there are things we can do. We have the regular mouthwash that we need to, that we know, but then we need to advise them not to use alcohol-based. So they need to use non-alcohol ones. And then we can also have the artificial saliva product, but they are very expensive in food eating. So that's what studies have shown. And then the only drug that I've seen in most studies encouraged to be used is saliva stimulation. We use the parasympathetic drugs, and one of them is the pilacopine hydrochloride. So this one is very good when the patient has radiation-induced xerostomia. So then when they are given this, you'll find that they recover very fast their saliva and they're able to produce enough. Okay, and then sometimes if there is pain, because when a patient has a lot of pain, you will find that they end up having xerostomia because now they are breathing with their mouth because they can't close it. Then you will find that then applying topical or systemic analgesics is very appropriate. But the most critical thing is to reassess and refer as appropriate to the specialist that can do. I know RFM will have Dr. Dube, if not mistaken, who is specializing on the mouth. So we can refer to those people who can then help in managing further that. Remember, the referral must be done based on the benefit and the harm, because you cannot take me dying, maybe I'm left with 2 days or 3, and then you say the patient must be taken from Lavomisa to RFM, but really, how much will they spend on that? So it's very important to assess and see end of life. But I'm hoping in our next modules, in future, we'll have time to look around this end of life issue and deal with it. Okay, but then we have what we call oral candidiasis in the life-limiting conditions at the end of life, more especially, or when they have this xerostomia. So we have the national guidelines, or you can use WHO guidelines on treatments. And then what we normally say is you remove the dentures before any treatment. So when there's candida, you provide mouth care, you provide analgesia, sometimes if there are those rinses. That's why having morphine is best, because it also helps when we are making rinses, you will do. And whenever you are using appropriate systematic treatments, which you will need to follow the WHO ladder as we treated in our previous modules, that how do we deal with pain. And then also you can have topical oral antifungals. Normally in the country I've seen us using most of the time Nestate. I don't know if other facilities have intraconazole and meconazole, but that's what we can use. And then also we can do systemic antifungals, especially when there's no response after 1 or 2 weeks of the topical antifungal, so then we can go for systemic. But remember, you need to follow the national treatment guidelines on this when you are treating this patient. Bear in mind to combine with the principles of pain of symptom management in palliative care when you are managing this patient. Don't give patient treatment that is not going to benefit them. Okay. So you need to weigh between these two. If then my mouth is ulcerated, also here we say continue with the mouth care we have already said, and address the mouth care and identify the cause and treat where possible, reverse the reversible, and then manage the non-reversible and alleviate symptom, do the counseling and do the education of the caregiver and the patient to alleviate anxiety and help them to cope with the stressor and manage the distressing part of it. Okay, sometimes it's caused by infection, tumor. I cannot mention many things, deficiency. So you need to know what exactly could be causing the ulcerated mouth. So you need to know what would be that. Then sometimes there's mucositis, post-chemo and radiation, you know. So you need to take a mouth care. If my patient is on chemotherapy or radiation, mouth care, always check your mouth care. Some of the suggestions, if unconscious and able to spit out, consider use of alcohol-free mouthwash or normal saline, okay? You can go for topical analgesia, paracetamol, morphine rinse, benzodiazepine, and hydrochloride, difluman, or Bonjela. You can use those topicals. If not responsive to the above measures, consider use topical anesthetic and apply directly to the painful area. So we have lidocaine. And then for those patients, when we are going to use this anesthetic medication, please avoid anesthesia to the pharynx before meals and drinks, because the patient might aspirate, and what do we call this bypass, when the food will go the other way. So for severe and oral pain, consider the combined use of topical and systemic preparations. So sometimes it's best to seek specialists. So if you have those oral mouth specialists, then you refer to them and then they can assist you. Maybe to close my presentation, I will go straight to the summary and say, as a symptom, dry mouth may be considered inconsequential. However, it has considerable quality of life implications. So if it has considerable quality of life implications, we go back to the definition given by WHO for palliative care, which has this special word there that is called the quality of life. So then we need to be very cautious, because the intention of palliative care interventions is to improve the quality of life and provide comfort, not harm. So then if this xerostomia has considerable complications on quality of life, then we need to manage it as possible as we can, because it can have detrimental effect on how we are taking care of our patients. So as clinicians, we must assess the distress from xerostomia and determine financial consideration to create suitable management. Remember that most of the things we can do in mouth care, we can buy them, because most of them they are non-pharmacological. So you need to find the level of distress. How much distressful is this xerostomia the patient going through? And then I can determine how much the financial strain my patient is going through, so we can look on a convenient intervention that will give us the same output, maximize, optimize whatever I'm doing. Oral care and education are essential strategy and may prevent severe damage. So always encourage our patients to keep their mouth clean and always educate them on how to do it and follow them through. It will save us millions and millions and save them a lot of expenses when it comes to social, psychological, and spiritual life, because they will lose friends and lose themselves. There is no stronger data maybe supporting that pharmacological interventions are stronger than non-pharmacological strategies. So the best way is use the best available for you. as early as possible. Families will need to help and manage the symptom as the patient declines. I've mentioned that most of these patients with life-limiting conditions, they have a declining disease trajectory and they are moving in this step slowly and slowly. So we need to prepare the caregivers on how best they can provide mouth care so that whenever my patient is going down, they help the patient. But when the patient can still, let me example, patients who are on ECOG 3 or Kinovsky around 40–50% or so, you find that they are able to brush their mouth very well. So we need to encourage them to do as what they can. My lecturer, my farmer usually say, don't create an environment of dependency. So use your ORMs to lift your patient from dependence to self-care. So move them towards that area. So we also encourage them to do that. But then when they have self-care deficit or they are care autonomy is going down, we need them to encourage the caregivers to do that for them. Patients in palliative care units need better mouth care. If you have a unit or you are admitting patients that are palliative care patients, for example, we have RFM who have patients who are admitted to the ward, and then we need to emphasize on mouth care. Every time I'm taking a routine visit to the facility or to the ward, let me ensure I don't leave the ward without checking the mouth care, because that will be very detrimental on the patient. Another thing we need to do is to understand that increased awareness among staff members about the presence and severity of oral problems is necessary. So we need to sensitize ourselves and our colleagues that, you know what, take mouth care as serious as possible. It has a very detrimental effect on the quality of life of the patient. Remember that the patient is a spiritual side, emotional side, psychological side, and then has a physical side. So we need to take care of all the sides of the patient. And then systematic information about oral problems is important in all stages of cancer treatment. If you could look at the common cause that will lead to xerostomia, chemotherapy radiation. So in all the stages of the cancer treatment, let's ensure that we have systematic information about oral problems and let it be known. Let's have charts, let's have SOPs, let's educate the caregivers, let's educate the staff, let's educate everyone involved so that we take care of our patients before the worst happens. Thank you so much, colleagues. That's what I can share as xerostomia is. But then I will leave this to you, colleagues, to add and comment and share your experiences around this before maybe then we can move together to get our RFM case. I will give ourselves 5–10 minutes to share on or react to this presentation. I said today, I hope most of us have seen this. So yeah, can I give everyone the opportunity now to share? What can you say? What have been your experience around dry mouth and mouth care, especially for our palliative care patients, across the disease trajectory journey as they are moving towards the end? I would be happy to see our comments. You can raise your hand and share what has been your experience in your area of practice, anything you have seen or you have met xerostomia. Were there any challenges? How best have you tackled them? I also have my team here. I'm hoping they've seen xerostomia many times. I think they can share something too. Okay. Anyone who wants to share something, or you wanna add something, or you wanna comment, you wanna, yeah. Okay, Joshua, you can share something.
Yes, I don't have anything to share, but I just want to thank you for this one, because for sure is that we sometimes meet with this patient, but in our side, I didn't know if there is some other management apart from mouthwash. We always do mouthwash like that, and maybe treating like fungal infection and some other thing, but it is really something which is terrible to our patient, most especially the patient cancer patients and these threatening illness patients like HIV and those sort of things. Last Friday we had a subject, a topic concerning care of mouthwash. I think they are all the same which you have presented. I have added some in my knowledge. So I just want to thank you so much.
Thank you.
That's all I can say.
Thank you so much, Joshua, for your input. Thank you so much. Yes. And remember, team, is that, I can have xerostomia due to the progression of the condition or other drugs I'm taking that are necessary for me to go. But, the effects are more than the mouth, because psychologically it affects me. That means then we need the IDT to be on board. We need the psychosocial, we need those specialists who can help us and advise wherever possible. We need some clients who prefer traditional medicines. Sometimes the learning curve. So it goes deeper. Some will even be affected spiritually because maybe they used to pray as a family, but now because I have xerostomia, I cannot even speak. So yeah, so we need to treat them around. Some will think maybe God is cursing them. If you have been a Christian and you have read the story of Job, Job once has boils all over the body, and people were thinking he was cursed by God. So those are the things that usually happen. So we need to find out. There are many things that then comes up when these patients have these distressing symptoms. So it's very best to manage them. And whenever another areas are affected and they show up, we quickly run and manage those things, allay anxieties, and educate and support them through. Okay, I don't know anyone from my side here, colleagues. Do you want to share something I want to share with the Ndulina? Okay, so whenever you're prescribing any drugs, be cautious what would be the effect and monitor them. Whenever the patient presents with xerostomia, find the root cause and then eliminate it. If it's infection, kill the infection. If it's another drug, find alternatives, you see. If it's a chemo, which is targeted to this, find some stimulator like the lipo, the drug, so it will help. So find stimulatories, look for non-pharmacological and pharmacological, non-pharmacological drugs and the pharmacological, non-pharmacological interventions and pharmacological drugs. They all have a side effect. Consider the financial strain that one has on the patient. Don't choose interventions that come so handy on the patient. That's a sign that you are saying to them they must fail and they might be guilty that they failed you. So look for a consensus. What could work for both of you and the patient in this situation? Okay. In the absence of any comment, may I give Julie, can I give you the opportunity to share your case? Can I share on screen, Julie?
Yes, Mr. Matlang.
Okay, thank you. Can I do that right now? There it is. I hope it's what we were looking for. Okay. Give me some few minutes. I want it to be big. Unfortunately, it's playing games with me. Let me try something else. Okay. I don't know why is it behaving this way, but I'm pushing it through. I hope very soon it will. Can you see it now?
Hello?
Yes, can you see it now?
Yes.
All right. You can go ahead, meeting.
Afternoon, colleagues. My name is Nonsikelelo Ntuli, palliative care nurse from RFM Hospital, Manzini, Eswatini. I'll be presenting our new case of a 50-year-old male with recurrent ischemic cerebrovascular accident, type 2 diabetes mellitus, and hypertension. The main problem or concern we have about the patient that the patient can't talk, he has bad breath, have septic sacral pressure ulcer, and bedridden. Chief complaints: on and off difficulty in breathing, can't talk, bad breath, body weakness, can't walk, sometimes pass foul smelling discharge on mouth. Since the patient can't talk, we had a difficulty in assessing the pain, but we asked from the wife, and she said that the patient sometimes frowns, and they are using Panadol to manage that pain at that time. Okay, can you continue? Okay, psychological.
Where are we now? I'm sorry. I'm lost here. Okay. Sorry, let me fix this thing. The laptop is behaving sad. It's behaving bad. Can I do like this? A little bit moment. Sorry. I don't know why is it behaving this way. I think now we are here. Yeah.
Okay.
We're on the physical side.
Assessment. Patient is bedridden, semi-conscious, respond on touch, mild pitting edema on left side of the body, can't talk, have bad breath, no pallor and dehydration, did gastrotomy, and have a gastric tube on, has urinary catheter on, uses disposable napkins, has necrotic sacral pressure ulcer, rash on armpits. Psychological aspect assessment. Patients rely on wife, his siblings and children for self-care, cannot talk nor walk. Social aspects. Patient is bedridden. Education. She completed her tertiary education. He's a clerical officer in one of colleges in Eswatini, socio-economic class, middle class, marital status, married, lifestyle habits, doesn't drink nor smoke, relevant health condition in the close family members. His dad died of prostate cancer. His youngest child was having asthma attacks and have outgrown it. Other social related information. He's a family man, married, have 7 children, eldest child 30 years old and youngest 15 years old. Spiritual aspect. He's a Christian who goes to an apostolic church. Significant medical surgical history. Patient was admitted in Babane Government Hospital from 5 December 2023 to 29 December 2023 with a diagnosis of recurrent CVA, type 2 diabetes, and hypertension. He was inserted a gastrostomy tube for feeding and urinary catheter. Uses disposable napkins on antihypertensive and anti-diabetes medication. He was enrolled on palliative care at RFM 24 January 2024 after seen at the emergency room and resuscitated. Pressure ulcer reviewed at ER by surgeon who did debridement since ulcer had a slough and ordered to change dressing every 48 hours. Relevant past medications. Client was found to have high blood sugar and was given normal saline 1 liter state atropine 15 international units subcutaneously, state flagyl 500 milligrams IV state and ceftriaxone 1 gram IV state. Current medication. Nifedipine slow release 20 milligrams PO 2 times a day. HCTZ 25 milligrams PO once daily. Atenolol 50 milligrams orally once a day. Aspirin 150 milligrams orally once a day. Atavastin 20 milligrams orally nocturne. Gliclazide 80 milligrams orally 2 times a day. Panado 1 gram orally 3 times a day. Fluoxetine 500 milligrams 4 times a day for 7 days. Advanced care directives. We also didn't discuss that with the patient. We are still planning to have a family meeting. Information review, vital signs. Temperature was 37 degrees. BP 125/99 millimeters of mercury. Pulse 141 breaths per minute. Respiration 24 beats breaths per minute and irregular. Saturation is 95%. ECOG functionality is 4. Other symptoms, pain was severe, but on and off. Dyspnea, sometimes patient was having dyspnea. Anxiety, no, there was no anxiety, there was no agitation, there was no depression, no, okay, patient was bedridden. Sometimes the patient vomits. Then RBS, it was 23.8 millimole per liter, which was very high, and it was managed. Further care plan, client died 15 January 2024 while the facility was planning a family meeting. She was supposed to come back for a wound dressing and review of his diabetes medication. He was also referred for hospice care. Thank you.
Thank you, RFM team, for the case. That's sad, but thank you so much for sharing. I think you have shared this case for on how best we can manage such a case when presented to us. Is there anything we can do for such a patient? And thank you so much for all you did for him. May I give the opportunity to you colleagues to comment and share what you think, what we think they could do better in the future in, because now the patient has passed on. Can I give the opportunity for us to share? What do you think went well? This is a patient diagnosed with stroke and presented at RFM at ECOG for terminal phase with end-of-life complications. And then they did the debridement, they did the hydration, and then pain management, and then they did the wound care. Yeah, in total, then the patient was due to review, but they never came back. So what do we think went well, or we think can be done maybe in future in such cases? I'm looking for hands that can come and share. Let's share, colleagues, let's share. We have seen such patients presenting to us. Actually, maybe we're still seeing some of these patients. What can we share? What can we say concerning this client? Is there anything they can do better than this? Or is there anything we feel like was missed? And how best they can do it better, maybe when the same similar case present to your facility, present to us as hospice? What can we do? No, I don't know who is here. Can we share? What can we share? This was the case. Stroke equals 4, self-care deficit 100%, equals 0 or equals 4, totally dependent, caregiver, wife, children involved. What can we do? When a case like this presents, is it easy to tell when a patient is going to die? Let's share. Has it been easy to tell if a patient is going to die? How is it easier for each one of us to see when a patient is approaching the end? And normally, what do we do? Yes, I'm looking. You can raise your hand or you can put it in chat. Is it easy? Is it easy to see when the patient is going to die? Normally it's not, right? If we could, yes, Joshua.
Yeah, okay, thank you. They have done their best, but in my opinion, though it is not easy to say or to air out when the patient is approaching to death, and we don't know when will he die, because death is something which is secret of God. God knows when we should go. Maybe we can just do like psychological support to the relatives, the family, and all. The best way is to continue the management, because the patient is already on ECOG 4 and he cannot do anything. He's actually is 100% depending on the relative and the healthcare providers. So I think psychological support is the best, and continues the same management. That's all I can say.
Thank you, Joshua, for sharing that. You know, one of the things they mentioned here, the patient had difficulty in breathing. I'm just imagining the wife by the side and the children by the side, seeing the patient gasping for air, you see. So when my patient has no history of a lung infection or has not been having challenges of breathing for some time, but all of a sudden now my patient is gasping for air, has a difficulty for breathing, is up and down. Those are symptoms that, you know, we don't know when the patient is going to die, but now this is end of life. The patient begins to have a lot of some abdominal discharges, and the wounds begin not to heal at all. Even how much we are trying to clean them, they are not healing, which might be due to the system of the patient is no longer now functioning well. And that's when the stress of the caregivers skyrocket very high. They wish for a miracle to happen. That's when what Joshua is saying, we need to provide a psychological care. Yes, let me close this here. Not together, sometimes we are caught in between thoughts of initiating end-of-life care and not initiating because of wrong perception from the patient, family, relatives. Yeah. So this is the tornado time. In palliative care, we talk about preparing for the worst when all is well. Here, maybe the challenge could be the patient has been experiencing the problem and was able to talk, but nothing was discussed. When I was with Joshua in Gauteng some time back, there's one thing they said. They said that we don't know when it's going to happen, but it's better to prepare for it before it comes. All right. So issues of end of life, I will say, once we have created a rapport with our clients, it's unfortunate to RFM that the patient just presented. There's nothing that much you can do. But once you have created the rapport, it's good to discuss these issues with the patients and so that they are ready. Even when they present to the facility, normally what research says that they normally know and see, but they want a different person to say something that they don't see. For example, they might say that our father is going looking at what has happened, but they just wish the doctor or the nurse can say he will come back again. But then if you ask them what they think, then they will tell you, We think our father is going now. And then that's when we begin to prepare them for that. So these symptoms, sometimes they are an indication that they were, but then you did a good job to take care of the patient. When he leaves, he must leave clean, nice, you know. But I'm asking this because these are the symptoms of death that were here. But then the question is, do we then give time for the family to prepare for them, that what is coming? Because running away and hide is not going to do good for them. So the best way sometimes is not to be brutal, but to sit down with them, engage our breaking bad news skills in delivering this bad news with them. And then we cannot determine when, but this is the journey. These are the signs that this might happen. But another issue is the reason we are requesting that all of us in the country, let's join hands together, initiate all patients on diagnosis. We want to avoid this harm on the patient. That usually happens when they're now exiting, because you find that now we try to do everything, which is wrong, to do everything, while we need to do what is best for the patient. So we try to do everything just to console the family and the patient, even if we see. And sometimes it leaves us as clinicians with guilt, feeling like we have not done enough, you know. So to prepare ourselves on the journey, because we also undergo grief when we are losing such patients in our journey. And having this patient undergoing such a pain of a bed sore and stuff, it tells us that this patient was missed in our system of palliative care. So let's continue, advocate for the establishment of palliative care teams or units in our facilities. It will help us eliminate all the cost and pain that comes with this. Okay. I hope there's a long message here. Mother Gamet is saying this was a very sad incident indeed. Thank you to the team, and may they be encouraged to continue caring and supporting. And I think they did what they could do, and the hidden things remain hidden until the last breath. For such a patient, one would wish that they would be kept in the hospital at least longer to observe and support the family since the condition was bad. However, the issue of long-term admission for such patient remains in limbo in the terms of hospital patient stay and availability of beds. Yeah, you know, that's why we sometimes need advanced care directives. Maybe the patient will prefer that, and then we'll see what to do. Is it beneficial, you know? Because we cannot keep the patient in hospital if it's not beneficial, and then if not. But you did all the best, because we linked even them with hospice. You did all what you could do. But then I think it's a learning curve for all of us, because in the country we are seeing more strokes coming. So let's put them. Actually, it's stroke, organ failures, all these patients. Let's promote initiation into palliative care as early as possible, so that these issues of end of life could be discussed, and the family members could be equipped with the skills how best they can manage and prevent some preventable issues like the pressure sores and stuff. But then how best they can manage end of life, and if the patients are still alive. You know, I've had an experience whereby we share with some patients. Some patients, they appreciate, you know, to be given the platform to talk about what they would want when the worst happens. So, and when they discuss that, it's very painful, but it's healing when the situation then happens. So we need to push as a team, and I think it is still a global issue, because palliative care is not yet well embraced, especially in our country and in African countries. So we need still to push and advocate for more. Anyone wants to add something? Otherwise, thank you so much, Ziggy, for sharing with us this. It was indeed a sad experience. And I hope you will prepare for bereavement support for the family, so that we can establish if they are grieving very well and the bereavement period is running smooth well, especially the caregiver. if you were able to establish who was the caregiver and the children, so to find out if they are able to cope very well with it. So I think you will need to provide that bereavement support for them. I think you do call them after the 2 weeks, and then you will call them to see if they are doing well, and then if they need counseling, so you can put your psychosocial team to support them through. I hope that one you will put in your plan and in this, so that they can heal well, because this was a very sad issue. Seeing your father discharging foul smell by the mouth is not easy. Yeah, so I think, so you can also get how they are taking this scenario and how they are coping well with it. Anyone else wants to say something? Okay. I don't see any comments. Thank you so much for joining. Thank you so much, Joshua, for joining us today. We hope we'll get more participants. Let's bring more partners. Let's bring more colleagues to these sessions. You know, today it's me who is sick. Tomorrow it's my parent. Tomorrow it's my relative. You know, let's equip one another. We need palliative care as strong as possible as you can as a team. And also, I'm hoping, Ziggy, you are also getting a time to heal yourself as a team there. But it's another story for another day, guys. Thank you so much. So we'll have our next session on the 6th of March. So there, today Nzigi presented a case of dyspnea, which is one of the symptoms of end of life. What do we do when a patient presents with dyspnea? So I'm happy that we've already provided an introduction and Nzigi with your case on this topic. So on the 6th of March, we will have this session on dyspnea. May we prepare for it? Let's bring others. You know, when a patient presents with dyspnea, what do we do when it's a palliative care patient? When a palliative care patient presents with dyspnea, what can we do? So we will come with the presentation and discussion. I will be very happy if you will bring your different cases, what has happened in your area, what worked for you, and how best to manage it. So we will be doing that on the 6th of March, same time, same place. What we can say is that if you go to our YouTube channel, Eswatini Hospice at Home, you will have access to all YouTube videos with all sessions we've undergone. And then if you go to iEcoSpark, the first iEco platform, if you log into iEco.rg, you will then have all the materials and video links for the sessions we've covered. So even this one, I think by 4 p.m. today in South African time, 2 hours from now, you will have it on YouTube. It will be premiering, and also it will be available, the link on iEcoSpark. The materials, the case for today and the presentation, it is available on iEco. You can take it and use it and read it, and then, you know, it will help us. Thank you so much for joining. Let's meet on the 6th of March. And let's continue inviting us to see how best we can help our clients. Thank you. May we all have a great day. I think our administrator will share with you the feedback link in your emails. Please share the feedback with us. For those who have not been able to join our WhatsApp group, where we are sharing the invites and everything, you can also share whatever you can on that community. It helps us communicate faster, but we don't have our emails. We will continue to use them. May you have a great day. Thank you.
Okay, thank you. Bye.
Bye-bye, John.